Good day, fellow learners. Once again, this is your mentor, your fact check buddy Ray Gapuz, joining you from our conference room here at the Ray Gapuz Review System Building, United Nations Avenue, Manila, Philippines. And I'd like to introduce you to the next set of clustered topics that I prepared for you. And I'd like also to remind you to please, if you still have adequate time after watching this set of concepts in this video, you may want also to watch Cluster A. Most of those topics there are still on trend, and those topics are still very much applicable if you want to ace your next generation NCLEX-RN test. So good luck and God bless. Enjoy the rest of the videos that I clustered to help you prepare for your next generation NCLEX-RN test. See you in my next video. Good day, fellow learners. Once again, this is your mentor, your fact check buddy Ray Gapuz, joining you for another discussion, this time around for case number 29. Now, on to what we're going to talk about today, seasonal affective disorder. Now, pay particular attention to the fact that seasonal affective disorder, as the term implies, occurs depending on the season of the year. So, the outstanding feature of this condition is the fact that the duration would usually last around 4 to 5 months or approximately 6 months. And you have what we term fall and winter seasonal affective disorder and spring and summer seasonal affective disorder. So it does not necessarily mean that when you say seasonal affective disorder, it only occurs during winter or fall. It can also occur during spring and summer. Now, what are the similarities and differences? Definitely, the similarities would be the onset of the symptoms could be related to the change in the season. And of course, there are symptoms that are specific to each of these subtypes. Okay, so for fall and winter seasonal affective disorder, you would usually see the client oversleeping, and then they would usually have craving for foods that are high in carbohydrates that ultimately leads to weight gain and eventually low energy levels. So that's how they are. Now, for clients having spring and summer seasonal affective disorder, the reverse occurs. So instead of oversleeping, they will have difficulty sleeping, they will have insomnia. Instead of increased appetite, they will have poor appetite. And instead of weight gain, they will have weight loss. And eventually, they will have behavioral problems like irritability. Therefore, if you get to see a client whose sleep patterns as well as whose mood could be related to the change in the season, you might as well advise that person to seek consult. They could be suffering from seasonal affective disorder. So, seasonal affective disorder is a type of depression that occurs at specific times of the year, often, but not exclusively, in the fall or winter. But as we said a while back, we also have seasonal affective disorder that occurs during summer or springtime. Okay? Now, the primary cause of fall or winter seasonal affective disorder would be due to reduced sunlight exposure. And this usually happens in North America, specifically Canada, where the weather is a little gloomy during winter. Now, what are the signs of seasonal affective disorder? Now remember, SAD. S, social withdrawal and sleep disturbance. It could be hypersomnia or insomnia, depending on the season. Anhedonia, or lack of interest in things that usually brings joy or pleasure. And of course, depression that is affected by the change in the season. Now, when a client has seasonal affective disorder, the priority intervention is light therapy. But let's apply that into the layman's understanding of what light therapy entails. Usually, you just have to advise the client that if the weather is gloomy, they need to turn on the bright lights in the house. So turn on the lights all over the house so that their mood could at least be heightened by the bright environment. Now, this usually involves exposure to bright light that mimics natural sunlight to help regulate the body's internal clock and improve mood. Now, discharge instructions on related to seasonal affective disorder clients would be, remember, blames. Okay, balanced diet. They should have enough carbohydrates, balanced with fats and protein. Light therapy, antidepressants if there's a need to. So they should be given antidepressants, and they should be told that antidepressants would usually take time before it works. Initial effects usually occur in 2 to 3 weeks, and the full therapeutic effects occur in 3 to 4 weeks. And pay particular attention to the fact that if your client is taking an antidepressant, there are at least 4 adverse effects that you will need to focus on. Like, for example, if they're taking selective serotonin reuptake inhibitors, they can have serotonin toxicity manifested by muscle rigidity, fever, seizures. Okay, and these things need to be reported to the healthcare provider because they need to either adjust the dose or stop the medication and change it. And then the client should maintain a routine sleep schedule to prevent insomnia or hypersomnia. They need to exercise. And the most important thing, since this is about depression, they need to seek social support from friends, relatives, and family. Okay, years. So here we go. Let's apply what we learned to a case study. A 34-year-old woman presents with symptoms of depression, fatigue, and social withdrawal. You have 2 of those main symptoms in our acrostic SAD. You have social withdrawal and then depression. Every winter for the past 3 years. That's a key phrase there. Every winter. So this becomes now part of what is expected when winter comes. And for those countries in which they will have winter for more than 4 months, chances are this is going to be seasonal affective disorder. With her symptoms improving during the spring and summer, okay, which is the most probable diagnosis of the client. Now, this can't be major depressive disorder because usually major depressive disorder will not last for several months. Usually, okay, this is not bipolar disorder because we don't have a manic state or a hypomanic state. And although depression and loss of energy are symptoms that could be similar for clients with seasonal affective disorder and chronic fatigue syndrome, usually in chronic fatigue syndrome, the symptoms would last more than 4 to 5 months. So the best answer for this situation would be number 3, seasonal affective disorder. Okay, so on to our topic for today. When you say frostbite, now this is common to those who usually guide people to go mountain climbing. Like, for example, at Mount Everest, you see a lot of Sherpa. Okay, these are the guides for those who love to explore Mount Everest. That's the highest mountain in the world. Okay, so frostbite refers to tissue destruction resulting from prolonged cold exposure and freezing. Now, it begins at temperature below negative 0.55 degrees centigrade, or that's equivalent to 31 degrees Fahrenheit. So at this point, you will feel the signs and symptoms and would go through the different degrees of frostbite, which we're going to discuss as we move along. Okay, so frostbite actually affects the fingers. Notice that these are distal parts of the body, the toes, the nose, the cheeks, the chin, and of course the ears, including the lips. Okay, so the first degree or frost nip of a frostbite is characterized by red or blotchy discolored skin with numbness and tingling. Now, numbness and tingling would mean that there's now beginning nerve damage in that area. That's a first degree, okay, frost nip. Okay, second degree, or the superficial frostbite, is characterized as bluish or purplish warm skin with blisters. Once again, second degree frostbite, you see blisters, okay? And then third degree or severe frostbite, the skin is characterized as blackened and hard skin due to freezing of deep tissues. Now, this is where there's loss of sensation that could probably be due to the damage to the peripheral nerve endings. Okay, treatment of frostbite includes protect the skin from cold. So we need to rewarm the skin, but we have to do that without necessarily worsening the injury. Then rubbing, bending, stretching must be avoided as it could potentially put a strain on the damaged tissues of the distal part of the body. Open flame exposure must be avoided as the sensation of the damaged skin could usually be impaired, and definitely open flame exposure could worsen the damage. And then soak in warm water. The temperature should be 98 degrees Fahrenheit to 108 degrees Fahrenheit. The important thing to remember here is that we need to rewarm the area that has suffered from frostbite. So here's case number 27. A 35-year-old mountaineer comes to the emergency department with some skin of the left foot pale and reddish with blisters, that's a key word, filled with milky white fluid with swelling, pain, and numbness. The nurse should implement interventions related to which degree of frostbite. Now, the fact that you have blisters, this is actually second degree. Okay, there's no fourth degree. Okay, the most severe one is third degree, where the skin looks black. Okay, when there's tingling and numbness, that's usually first degree. So the answer here, second degree. Okay, on to our case number 24. And this time around, we're going to talk about pneumothorax. But before we do so, let me first congratulate this gentleman from Naga College Foundation. His name is Jerkin P. Devara. Now, USRN in the state of New York. Thank you, Sir Ray Gapuz, and to the staff. I passed my NCLEX-RN on August 28, 2024. The bootcamp helped me a lot in focusing since there were no distractions, and the method of teaching done by Sir Ray himself was very effective through active learning and repetitive assessment. The book NCLEX-RN NCLEX 311, which was provided during the review and which I have read from cover to cover, is very informative and written in a very simple but comprehensible manner. I will give the review center a 10 over 10. Thank you. Thank you for the very kind words and congratulations, Mr. Jerkin P. Devara from Naga College Foundation. And on to our discussion of pneumothorax. Now, pneumothorax occurs when air collects in the pleural space between the lungs and the chest wall. Now, may I draw your attention to the illustration from Wikimedia on our right side? So this is trying to differentiate the normal lung and what happens in pneumothorax when the pleural space collects air. So that air now will compress the lungs, leading to shortness of breath and then absence of breath sounds, and definitely there's going to be chest pain if this is secondary to trauma. So it is initially manifested by sudden sharp chest pain on one side of the chest and shortness of breath. So what are the common causes of pneumothorax? These include lung disease, injury to the chest, like for example, if the client had motor vehicular accident. For lung disease, COPD, like emphysema when there's rupture of a bleb, that's an over-distended alveoli. Assisted ventilation or the use of mechanical ventilation could potentially lead to pneumothorax and ruptured air blisters. Remember, LIAR, lung disease, injury to the chest, assisted ventilation, and ruptured air blisters. Now, the management of pneumothorax include needle aspiration and chest tube insertion. May I draw your attention to please do kindly view pointers number 49 on our YouTube channel, specifically on the topic thoracic catheter, that contains an extensive discussion of the use of chest tubes in order to manage pneumothorax. And let's use what we've discussed to answer case number 24. So the nurse is assessing several clients from a car crash, which assessment finding in the client requires immediate intervention by the nurse. Now, that is actually very, very important to know, okay? So, here we go. The first one that we have there is actually a question, an option on the presence of bronchial sounds at the base of the neck. Bronchial sounds are normally found at the base of the neck. So you have bronchial sounds, then bronchovesicular, and at the base of the lungs and all throughout the lungs, you have your vesicular breath sounds. Now, your vesicular breath sounds are normal breath sounds, and these are low pitch, okay? So the breath sounds are low pitch. It could be muffled, and they have been described as rustling sound, similar to a gentle breeze through the leaves of a tree. That's a description of vesicular breath sounds. And these are normal breath sounds. Now, what is abnormal is when you hear your bronchial sounds not at the base of the neck, but at the base of the lungs. So that could indicate pneumonia. But our discussion is not about pneumonia. It's about pneumothorax. So number one, presence of bronchial sounds at the base of the neck. This is normal. Two, unequal breath sounds in one side of the chest. We can consider this because, as we've discussed, when there's compression of one side of the lungs, that could potentially lead to a diminished breath sounds. And then bronchovesicular breath sounds at the first and the second intercostal space, that's also normal. And then your soft, breezy, low-pitched breath sounds, these are your vesicular breath sounds that are found throughout the lungs. So definitely the answer to this question is option 2, unequal breath sounds in one side of the chest. And that requires further evaluation from the healthcare provider. Now, let's talk about the condition which you can potentially develop from our very rigorous system of doing the NCLEX test prep. So let's talk about migraine. But before we do so, let me congratulate one of our young passers, Joshua H. Hermenegildo. From the City University of Pasay, he just graduated last year and became a Philippine registered nurse just December of last year. And look, in less than a year, he's now a USRN. He passed the New Mexico Board of Nursing last September 27, 2024. Congratulations, Joshua. And this is his success recipe. Trust the system, trust yourself, and you'll be next. Good day, Sir Ray. I'd like to share some good news. I passed the NCLEX-RN. I took my exam last Friday, September 27, 2024, and after 3 hours and 40 minutes, my computer shuts down at 85. The NCLEX-RN is a different type of exam, systematic and methodological. I have 5 case studies and mostly standalone questions. The 5 case study is lengthy, but I always tell myself to go slow. Don't rush. I find the standalone question to be more difficult. You'll never see keywords or clues, as most questions are one-liner. They really test the concept mastery. Whenever I encounter a difficult question, I pray, read the question, and go back to the function, and read the question and go back to the functional concept method. That's his success recipe. Way to go, Joshua. Great job. And my NCLEX journey is extensive, and he attended the boot camp, 1 cycle of comprehensive review. He answered TOP, that's our test overview program, and he did the core shells, that's our Q bank with videos, which I answered twice, and 2 QUICKFIX. All parts of the program are helpful and complementary to the NGN. Most of the questions I encountered were discussed in the QUICKFIX. I told you, don't miss my QUICKFIX. To be honest, sir, our Q banks from TOP and core shells were more difficult than the questions I have encountered. The books that helped me the most are QUICKFIX in Pharmacology, the new NCLEX 311, which I co-edited, and the nursing reminder sheets. All of your YouTube videos are helpful. I encountered the concept you've discussed in the 2020-2021 video. Thank you, Sir Ray, for your guidance. You're the best. To our mentors, Ma'am McLean, Ma'am Che, Sir Francis, Ma'am Sol, Ma'am Nicole. Thank you to all of you. Lahat po kayo magagaling. All of you are good. Thank you to my Ray Gaps Review System family. Our system really works wonders. To my family, thanks for your support. Most importantly, thank you, Lord. That's from Joshua Hermenegildo from the City University of Pasay. Way to go. Now, let's talk about migraine. Now, migraine is a genetically influenced disorder manifested by moderate to severe headache that comes with nausea, vomiting, dizziness, and light and sound sensitivity, which could potentially trigger spasm of the arteries in the brain. Sometimes the spasm could come after eating some foods with MSG. So it's important to avoid MSG and those that contains thiramine or those that have preservatives. So there's an herbal remedy for migraine headache. Here's a tip. It's called feverfew. Okay? Feverfew is for migraine headache. So before a migraine attack, an aura described as flashes of light or blind spots would usually occur. And the symptoms that may occur after migraine attack includes, remember, FMNI, food craving or frequent yawning, just like having narcotic withdrawal when your client would have excessive yawning, mood changes, neck stiffness, like a client having meningitis, and increased urination. So what are the triggers? Remember, shades. It could be triggered by stress, hormonal changes in women, additives in food like MSG, drinks, extreme weather, and sensory stimuli, as well as sleep changes. Those of you who either are insomniac or they have difficulty sleeping at night because of some problems, emotional concerns, or pain, then they are at risk for having migraine. So treatment of migraine includes your triptan, sumatriptan, frobatriptan. Okay, these are all indicated for clients with migraine. The antiemetics like chlorpromazine, which is an antipsychotic with antiemetic properties, your Gepan, Savegepan, okay, nasal spray, your lasmiditan oral tablets, and dihydroergotamine or migranal. Okay, these are all considered as treatment for migraine, but focus on the triptans. Sumatriptan, frobatriptan, eletriptan. That's a tip. Okay, so let's answer case number 23 using the concepts that we've talked about. So a client with migraine headache describes feeling severe pain even if the trigger does not normally provoke pain. Now that's an important phrase to consider, severe pain even if the trigger does not normally provoke pain. So this question is more likely going to ask us about a terminology that we can use to label what the client has shared in terms of the symptoms. So which term can be used to describe the client's symptom during documentation? Is it allodynia, peripheral neuropathy, analgesia, or odontalgia? Now, odontalgia is plain and simple toothache. Analgesia is actually the absence of pain. Peripheral neuropathy indicates nerve damage, and it comes with tingling sensation. So allodynia is severe pain that is triggered by something that does not normally provoke pain. So the answer in this question is 1, allodynia. Now, on to our NCLEX-RN alert. Let's talk about post-traumatic stress disorder. So PTSD in short is a psychiatric disorder that occurs in one who either witnessed or experienced a traumatic event. Like, for example, if you had the experience of witnessing a shooting incident during a heavy traffic flow while you are driving, you could experience PTSD, or it could be as simple a situation as big dogs were running after you. That could also be traumatic, and you can experience PTSD. Now, in PTSD, the symptoms would usually appear in 4 to 6 weeks after the incident. So, it may result from experiencing threats on a person's life and well-being. And what are these situations that could potentially lead to PTSD? You have here the code PTSD: pain, traffic collisions, sexual assault, and of course, domestic violence, or this could be associated with a husband or a wife who is a batterer, or a domestic partner who is abusing you either physically, emotionally, or financially. All of this could actually trigger post-traumatic stress disorder. Now, PTSD symptoms reflect physical and emotional reactions like insomnia or difficulty having a sleep at night, getting easily startled, irritability, and even confusion, avoidance, staying away from places that remind the traumatic event. Now, the ability of the client to go back to where the trauma once occurred is a reflection of stage 3 on the road to recovery. We'll talk about that in a while. And intrusive memories, flashbacks, and nightmares that they experience while they are asleep. And then negative changes in thinking and mood, in which anger or numbness could occur. Numbness, which simply means that the client may try to shield themselves from the emotional trauma by simply not reacting to the situation. They become nonchalant to the situation. So PTSD treatment is geared towards enabling the client to gain control of their lives. So at least the symptoms would actually not go away, but at least they're able to control how they react to the symptoms. And that is what is important in PTSD treatment. So the main PTSD treatment is talk therapy. So they have to find a psychotherapist to enable them to facilitate catharsis or the emotional release as they talk about their experiences. Now, PTSD treatment also includes exposure therapy, in which the client is prepared to face the traumatic situation, cognitive therapy, in which they try to convert negative thinking that's trying to hold them back into a positive approach of coping by reflecting and learning from the negative experience, and the use of antidepressants, especially if they develop depression after PTSD. Now, face-to-face support from others is the most important factor in PTSD recovery. That's why support from family, loved ones, partner, the husband, the wife would actually help the patient recover. So exposure treatment for PTSD helps the client face frightening situations and memories. And cognitive therapy for PTSD helps the client identify negative beliefs that keep the client stuck. So remember, exposure treatment helps the client face frightening situations. Cognitive therapy focuses on the thinking process of the client, helping them to identify negative beliefs that keep them stuck and developing coping mechanisms to transform the negative beliefs into a more positive outlook. Okay, now there are 5 stages of PTSD, and these include impact or emergency stage. That's stage 1. In this stage, the client struggles with the experience. PTSD symptoms like flashback, nightmares still manifest. So the priority for the nurse is to ensure safety of the client and stabilize the client. The focus should be on reestablishing a sense of trust, specifically trust on the ability of the client. You have to bring that trust back because they lost it, especially when they are in an abusive relationship. Second stage is the denial or numbing. Now, this is actually numbing. This is actually the attempt of the client to shield themselves from the trauma. So they try to avoid difficult situations. And this is where professional help is needed so that it can help facilitate recovery. Third stage is the rescue stage, in which the client comes to terms with the experience. And an example of the behavior of coming to terms with the experience would be the client goes back to the site where the trauma occurred. This is their way of processing the traumatic experience. And the therapist or the nurse has to be patient during this stage because the client can fluctuate. That simply means we don't expect them to progress immediately to the next phase or to complete recovery, because sometimes they go back and forth to the different stages, from stage 3 to 2, or even from stage 3 to stage 1. The impact or emergency stage. And then short-term recovery involves transitioning to acceptance and having a plan for a sustainable recovery. Now, this is the time in which the client begins to create plans for the future. And that's realized in stage 5, long-term reconstruction, in which integration occurs. The coping mechanisms that are learned from the experience are then solidified and created for the future. So the priority of the nurse here is to connect with others, and therefore their focus would definitely be on enhancing the client's identity, because sometimes they feel that they've lost so much of themselves, and sometimes because of the trauma, they're unable to experience gratification from intimate moments that they spend with their loved ones. And that is very, very important in terms of the long-term recovery of the client. Now, let's move on to case number 22, and let's read through it. After being involved in a road rage incident, So this could be the traumatic incident for the client. A week ago, that resulted in a traffic collision of several cars. A 32-year-old male comes to the emergency department for treatment of high blood pressure and palpitations. That indicates anxiety attack or an activation of the autonomic nervous system. Further evaluation reveals insomnia and frequent nightmares. The client undergoes psychotherapy. So there you go. There's a giveaway. You have insomnia and frequent nightmares, which are characteristic symptoms of PTSD. So in the early stage of the interaction between the client and the therapist, which of the following reactions is expected from the client? Is it ambivalence, increased insight, focusing on the future, feeling more confident? Now, the increase in insight, focusing on the future, and feeling more confident, these are all achieved during the reconstruction stage. So in the early stage of PTSD, as we've talked about, sometimes the client may not progress and they can fluctuate from stage 1, the emergency phase or the impact phase, and onto the other phases. So that reflects ambivalence or the development of opposing feelings towards a situation. It's like love and hate coexisting together. A sense of hope or a sense of being defeated could coexist, and that's ambivalence. So the key is be patient if you are the therapist or the psychiatric nurse. So once again, the answer is 1. Okay, now on to our NCLEX-RN alert, moniliasis. Now, this is a yeast infection. It's caused by a fungus called Candida albicans, usually occurring before menstruation. Now, candidiasis could also occur in the mouth. So in some clients, they have oral candidiasis, especially those who are using inhalers when they're having asthma attack. That's why it's very important that they have to use spacers and do the swish and spit method after using an inhaler. That would definitely decrease the incidence of fungal infection. So this is manifested by thick white cottage cheese-like discharge. So that's the characteristic manifestation. Pay particular attention to that. White cottage cheese-like discharge. And this occurs immediately before menstruation. That's why the choice of sanitary pad is important. Choose the sanitary pad that's not scented so that the chemicals will not irritate the area. And possibly you can choose the sanitary pad with wings, or not just the wings, but with bird. Of course, that's a joke. I'm just kidding. The wings and the bird in the sanitary pad. Now, moniliasis is common among the following. Remember, CHAPI, catheter users, hospitalized individuals, those who are using hormonal birth control pills that potentially increases the estrogen, and this also occurs during pregnancy. The increase in estrogen causes hormonal imbalance that could potentially increase the risk for developing your yeast infection. For pregnant individuals, once again, because of the hormonal change, people with dentures and diabetes, well, especially if the diabetes is not controlled, and for young individuals, your babies and children who usually have an immune system that have yet to mature. So moniliasis is manifested by pain and soreness in the vagina, itching, cheese-like vaginal discharge, painful intercourse and urination, irritation in the vagina, and change in vaginal color from pale pink to red. That signifies irritation. Remember, the code moniliasis is manifested by PECHA. Okay, so let's move on. So moniliasis is treated with echinocandins like your caspofungin and anidulafungin. Now, remember, your echinocandins can also potentially cause gastrointestinal irritations, nausea, vomiting, diarrhea, and they can potentially cause hepatotoxicity and thrombophlebitis. So it's very important that the clients are told about these potential adverse and side effects. And of course, it could also be treated with antifungal creams, ointments, tablets, suppositories like your terconazole, thioconazole, and of course, your clients could also be asked to take metronidazole. Now, what are the things that you have to remember related to metronidazole? Sometimes, 4 tablets of 500 milligrams are given to the client. They have to take it all at once with a glass of water. And this could potentially cause the brownish discoloration of the urine. And it's important for the nurse to reassure the client that it's not a cause for alarm. Okay, so some doctors would prefer to give the metronidazole 2 doses in 1 day and then give it in a period of 10 days. But some would definitely give it with 4 tablets and given all at once, okay? With a glass of water. Okay, so here's our case number 21, okay? 27-year-old female seeks consult for burning on urination and non-foul smelling whitish curd-like vaginal discharge that she describes as like cottage cheese. Which of the following factors could have contributed to the client's condition? Okay, the question is could have contributed, and you don't have a diagnosis. Still, think through the symptoms that were provided, like having the cottage cheese-like discharge could mean the client could be suffering from moniliasis, okay, or candidiasis. So could this be related to decreased estrogen levels? We talk about elevated estrogen levels, not decreased. Use of scented sanitary pads, we can consider that is irritating. Changing use of, controlled diabetes mellitus, it should be uncontrolled diabetes mellitus. Changing to dry clothes immediately after a long gym time, no, that would definitely help prevent the development of candidiasis. So the answer to this question is the use of scented sanitary pads. On to our NCLEX-RN alert. For this case study, we're going to talk about gastritis. And of course, the best way to recall concepts would be through our method, the functional concept. So gastritis is the inflammation of the lining of the stomach. Therefore, any drug that could potentially irritate an inflamed GI lining is considered contraindicated, like your non-steroidal anti-inflammatory agents like aspirin that could potentially cause bleeding, and the ibuprofen or Motrin. Those 2 medications could potentially worsen the pain. Now remember, if a condition ends in itis, like pancreatitis, gastritis, colitis, you have an inflammatory condition. And the best way to promote recovery is to promote rest. How do you promote rest in the GIT? Keep the client initially NPO. That should be your priority, whether the case is gastritis, colitis, or pancreatitis, okay? So gastritis could be acute, or it can also be chronic. It can be associated with, remember the code SAD, smoking and stress that increases secretion of hydrochloric acid, alcoholism and autoimmune conditions, and of course, the use of a specific drug like your non-steroidal anti-inflammatory agent. So the symptoms of gastritis includes, remember, BAN, so bloating, you feel full even if you've not really eaten, blocked blood in the stools, which could mean that there's bleeding in the upper GIT and the blood could have been partially digested. That accounts for the blocked color, and of course, a blocked vomitus or coffee ground vomitus as they describe it. And this could mean that there's digested blood in your vomitus. Then heartburn, anorexia and abdominal pain, and nausea. Remember, BAN. So gastritis can be diagnosed with upper GI series and the upper endoscopy with biopsy, which entails visualization of the upper GI tract. Now, usually that's treated with bismuth subsalicylate. Now, pay particular attention to the fact that your bismuth subsalicylate helps decrease the inflammation of the stomach. And then, of course, combination of antacids and antibiotics like clarithromycin, sucralfate that coats the GIT, so it serves as a protectant. Antacids like cimetidine that decreases the secretion of hydrochloric acids, antiemetics like ondansetron that manages the vomiting, and proton pump inhibitors like esomeprazole, which also helps control acid secretion. So remember, BASAP, like B-ASAP, bismuth subsalicylate, antibiotics, sucralfate, antacids, and proton pump inhibitors. So here we go for our case number 20. A 33-year-old male seeks consult for abdominal pain and blocked stool. So this should tell us that since there's an abdominal pain, we could very well figure out that the client could be having an inflammatory action, and blocked stools could mean that the client could be having upper GI bleeding. He tells the nurse that this occurred after he was treated for traveler's diarrhea. Now, traveler's diarrhea is common to those travelers to rural areas. So this is associated with giardiasis. And that tells us, therefore, that the client could be having an infectious condition that could have worsened the client's abdominal pain. Now, which medication that the client is taking should the nurse need to clarify with the healthcare provider. The important phrase here that you have to focus on would be the phrase need to clarify, which simply means which one is not helping the client's condition. Is it one ondansetron, that's an antiemetic, ibuprofen, that's a non-steroidal anti-inflammatory agent, clarithromycin, which is an antibiotic, and esomeprazole, which is a proton pump inhibitor. Among those that we've discussed, we agreed a while back that your non-steroidal anti-inflammatory agents could potentially worsen the bleeding in a client with gastritis. So the answer to this question, which one needs to be clarified to the healthcare provider, would be ibuprofen. Okay, and on to our NCLEX-RN alert for case number 18, and this is about Zollinger-Ellison syndromes, or ZES. Now, this is actually a tumor that occurs either in the pancreas or the upper part of the small intestines, and these tumors would usually increase the secretion of acids in the GIT. Now, what are the common risk factors to ZES? Remember, FM. First degree relative who have it, like for example, a sibling or your mom or your dad had it, so you are at greater risk for developing ZES. And then multiple endocrine dysplasia type 1, okay? Your multiple endocrine dysplasia, neoplasia rather, type 1 would usually affect the 3 Ps, the pituitary gland, the parathyroid gland, and the pancreas. So PPP, pituitary, parathyroid, and the pancreas. Now, there would usually be tumor growths in those organs in the body. There's also multiple endocrine neoplasia type 2 or MEN2 that affects your PTA. P, that's your parathyroid, T, thyroid, and A, adrenal glands. So your clients who have MEN type 1 or MEN1 are more at risk to CES, okay? So your Zollinger-Ellison syndrome is manifested by the presence of burning upper abdominal pain that's almost like your peptic ulcer disease, and then heartburn that occurs in clients with GERD, acid reflux, nausea, anorexia, and vomiting, diarrhea, and of course, stomach pain. Now, pay particular attention to the 3 symptoms. You have burning upper abdominal pain, acid reflux, and diarrhea. This could tell you that your client could be having ZES, but definitely the symptoms needs to be supported by laboratory data that includes the following: blood test for gastrin levels, which will be increased because of the presence of the tumor that stimulates the secretion of gastrin, your ultrasound that reflects the presence of the tumor, MRI or CT scan, and including your endoscopy. So the treatment for CES would include surgery to remove the tumor, and then chemotherapy after to prevent the recurrence, like administration of doxorubicin to prevent the spread of the tumor or gastrinomas, and then octreotide to counteract the excessive release of gastrin, and of course your proton pump inhibitors like your pantoprazole or esomeprazole to reduce the acids. Therefore, pay particular attention to these treatment regimens, specifically the drugs, as chances are this could be potential frequently occurring concepts on your test. So on to our case number 18. Here we go. A 40-year-old male client with inherited tumor of the parathyroid glands. There you go. You have an inherited tumor of the parathyroid gland. So you have men, either type 1 or type 2. 6 consult at the emergency department for stomach pain, acid reflux, and diarrhea. You see those 3 main symptoms that are frequently found in clients with CES. And so the question would go on to ask, the nurse should anticipate the administration of all of the following drugs to manage the client's condition except. Okay, so doxorubicin, that's a chemotherapeutic agent. Lansoprazole and omeprazole are proton pump inhibitors, which are usually given in order to neutralize the excess gastric acids. And of course, definitely ibuprofen is a non-steroidal anti-inflammatory agent that could potentially irritate the stomach lining. So the exception, therefore, is, as you guess it, you're right, ibuprofen. That's the correct answer. So we're going to talk about Bell's palsy. Now, there's one important thing that I'd like you to remember about this condition. It affects cranial nerve number 7. So cranial nerve 7 is your facial nerve. Your facial nerve is a mixed nerve. It has a sensory root and a motor root. The sensory root of your facial nerve is responsible for the sense of taste in your anterior tongue. So it simply means that you can try to test it by dipping a cotton tip applicator into different flavors and then rubbing it against the client's tongue. Okay, and then for the motor functioning of the facial nerve, you can test it by asking the client to make face, to smile, to frown, okay, and then observe how the facial muscles move. So once again, sensory root for the sense of taste for the anterior tongue, and motor root for facial muscle movement. So if your cranial nerve 7 is affected by this condition, then can expect that there could be weakness on one side of the face, and the smile would be unequal. Definitely there's going to be difficulty in closing the eyes on the affected side, which could eventually, potentially, could lead to blindness, either temporary or permanent blindness. Okay, so Bell's palsy or acute peripheral facial palsy is a temporary condition. It actually goes away even without treatment, and sometimes complete recovery occurs in 6 months. It's characterized by inability to move facial muscles on one side, change in taste, pain around the ear. So the client could experience any one of these symptoms initially. So it is characterized by, number mild to total paralysis of facial muscles, increased sensitivity to sound, loss of taste, and drooling or excessive salivation. So the risk factors to Bell's palsy include pregnancy. So this occurs commonly in pregnant women, especially those who are in the 3rd trimester, high blood pressure, those who are obese, and of course with diabetes mellitus. Remember, PHOD. So clients with Bell's palsy recover with or without treatment. Usually, the treatment would involve the administration of corticosteroids like prednisone, antiviral agents like acyclovir, and of course, in extreme cases, surgery could be done, especially if there have been facial deformities that could have resulted from the client's condition. Now, it's important also that clients with Bell's palsy should be referred to a physical therapist who could very well teach the client on how to perform exercises and massage on the facial muscles. So let's move on to case number 16. So a pregnant client with history of diabetes mellitus comes to the emergency department due to drooling and facial drooping. Pay particular attention on this specific set of data. So pregnant with history of diabetes, and there's drooling. So there's a combination of risk factors and symptoms, and facial drooping. So that's a giveaway. So the client has recently recovered from adenovirus pneumonia. So you have a viral infection, which is oftentimes the trigger of Bell's palsy. It could be chickenpox, adenovirus, Epstein-Barr virus, okay, infection. And due to the manifestations, the nurse should refer the client to which member of the interdisciplinary team. So in your mind, you have to identify the client's diagnosis before you are able to answer the question. So an endocrinologist is a doctor of medicine who specializes in treatment of endocrine disorders. Andrologist is a doctor of medicine responsible for conditions associated with fertility issues in males, like low sperm count, so refer them to an andrologist. A podiatrist is a doctor of podiatry responsible for treating conditions of the feet and, of course, performing surgery on that area, including the ankles. And a physical therapist is responsible in providing care, creating and designing exercises for patients who have problems related to pain, or those who are in traction, or those who have concerns related to gross motor functioning, like walking, turning, bending. You need to refer them to the physical therapist. So in this case, the answer to the question is actually number 3. Okay, to our topic for today's discussion, and this is about conduct disorder. Now, conduct disorder is characterized by the keyword consistent pattern of aggressive and disobedient behaviors. The onset is between 10 to 19 years old. Now, this is where I'd like to highlight the differences in terms of onset from several other conditions which may have almost the same presentations as your conduct disorder. For example, oppositional defiant disorder, the onset is usually from 5 to 10 years old. And then you have antisocial personality disorder. The onset is usually 18 years old and above. And of course, your attention deficit hyperactivity disorder in DSM-4, the onset is before 7 years old. But in DSM-5, it has been updated to before 12 years of age. So it's like if you have these behavioral patterns associated with aggressiveness and disobedience from age 5 to 10, think about oppositional defiant disorder. If you have it from 10 to 19, think about conduct disorder. And if you have it from 18 years old onwards, then think about antisocial personality disorder. However, if you have hyperactivity apart from the aggressive behavior and impulsivity, then you can consider attention deficit hyperactivity disorder, especially if the child is yet to turn 12. So the onset of ADHD is before 12 years of age. Now, what are the common risk factors for conduct disorder? This includes, remember the code LOT, low socioeconomic class, abuse of drugs or substances by the parents. So these kids grew up in an environment where the parents are abusing substances, which could have contributed to the maladaptive pattern of behavior that the child developed. And of course, domestic violence. Now, your conduct disorder is characterized by, remember, DADS, destruction of property. So the person could be throwing properties, or they are just secretly destroying things that you love. Aggression toward people and the animals. They're cruel towards animals. They use the animals for experiments. And sometimes you'll get to see your dogs already tied and tied to a tree, or you get to see your pet bird already tied also, and at the same time placed near a dog. Okay, so they could also be deceiving, lying, or stealing. Sometimes they have serious violation of rules. Now, serious violation of rules is also an outstanding manifestation of antisocial personality disorder. They habitually break the law. So there's a great chance that a child with conduct disorder eventually progresses into a person with antisocial personality disorder. Okay, so these types of children therefore could engage in verbal threats, or they could be engaging in bullying behavior while in school, or they could have truancy, which means they're not attending classes or they're cutting their classes. And the treatment for conduct disorder includes a multidisciplinary approach. So since the origin of the condition is in the family, so we begin with the parent management training. So we teach the parents what to expect of the child and how they promote normal growth and development. And then, of course, psychotherapy or talk therapy to handle the hostility of these children. Anger management training is indicated. And of course, in order to modify their thinking process, cognitive behavioral therapy is also indicated. Plus, if there's a facility in the community, a school where where their behavior can be properly handled, then we refer them to a community-based treatment facility. So here we go. Let's answer case number 15. The parents of a 14-year-old were called for a meeting with the principal and the school nurse. The class advisor noted that the child has been frequently absent in his classes. The parents arrived separately. That's a red flag. The child has been living with the grandparents, another red flag, and has been recently involved in verbal fights with some friends. So once you get to see the red flags, focus on the onset of the behavior. So you have here a 14-year-old child. So what did you say a while back? If you notice some behavioral disturbances from 5 to 10, it could be oppositional defiant disorder. Then 10 to 19 could be conduct disorder, and then 18 and above would be antisocial personality disorder. So we can consider those things. So let's move on to the sample question. So the nurse should suggest a set of interventions to address the child's condition, which is most likely associated with, is it attention deficit hyperactivity disorder? We don't have the impulsivity and the hyperactivity. We didn't notice that in the situation. And the onset is already past the age of 12. ADHD will have the onset before age 12. According to DSM-5, DSM-4, onset is before age 7. Conduct disorder, well, it's within the age of onset. 14 is within 10 to 19. Oppositional defiant disorder, well, the age of onset is from age 5 to 10. So in our case, we have a 14-year-old client. So we may not potentially consider number 3 as the correct option. And of course, antisocial personality disorder, the onset is usually age 18 and above. So the best answer to this question is option number 2, conduct disorder. So let's begin with pointers set number 42. So the first question that we should ask ourselves is, when we're preparing for the next generation NCLEX, what do we need to study? Of course, as a learner, we can't do that alone on our own. We need an expert opinion. And when you say expert, real experts, people who just did not pass the test and then taught right away, but people who have immersed themselves into the test framework of the NCLEX-RN. And that's who we are at the Ray A. Gapuz review system. We have been in this business since 1994, and we have produced hundreds and thousands of nurses worldwide, most of them with very inspiring stories. Okay, so let's begin with our first set of pointer, and that's going to be related to cataract. So we'll talk about cataract, and for this specific condition, always remember, pay particular attention to syndrome, meaning a group of symptoms that potentially describes the presence of cataract, like the gradual loss of central vision or opacity of the crystalline lens. It is painless. Some clients would describe it as blurry vision. Some would even complain of double vision, and some would complain about sensitivity to glare and frequent changes in their eyeglasses. Okay, now what are the things that we have to remember? First and foremost, cataract is related to aging, and the treatment would usually involve surgery, like surgical removal of the cataract, and that would entail the administration of drugs, like preoperative medications that could help dilate the pupils to prepare the area for surgery. And the example of these drugs could be phenylephrine, okay, atropine sulfate, and of course, your homatropine. Now, these drugs can dilate the pupils, will dilate the pupils, and these drugs are indicated preoperatively for a patient with cataract, but not for patients with glaucoma, as this could potentially increase the intraocular pressure. Okay, now, after surgery, what should be the focus of your discharge instruction? First and foremost, among those instructions that you will provide the client should be on keeping the area safe from unconsciously scratching it. So we have to tell the client to wear eye shield, okay, for the area that has been subjected to surgery. And then after that, we need to instruct the client to avoid certain activities which may potentially lead to complications, like, for example, bending or coughing or lifting or any activity that may increase intraocular pressure. Now, it's not actually directly contraindicated for the client to read, but reading or moving the eyes within 24 to 48 hours after an eye surgery is not comfortable. So it's uncomfortable. So better yet, we need to tell the client to avoid these things. And whenever a patient has undergone eye surgery, it's very important to include in the discharge instructions certain complications, specifically those that would require immediate intervention from the nurse, like bleeding. Now, how can this be manifested through a group of symptoms? So remember, think syndromic. So report any sign of severe eye pain after cataract surgery, because this indicates that the client could be having hemorrhage or bleeding, or the presence of visual floaters, like the patient would say, I see cobwebs in front of my eyes, I see veil-like structures in front of my eyes. This could potentially indicate retinal detachment. And of course, intraocular pressure could also be increased after surgery. So report if the patient experiences pain, nausea, as well as vomiting. And of course, whenever there's a discharge that could be greenish or yellowish, then you also need to report this, as could potentially indicate that the client could have developed infection. Okay, so those are the things that you need to highlight when your patient is being given discharge instructions post-cataract surgery. So the next thing that we'll focus on will be the concepts related to glaucoma. Now remember, glaucoma is due to increased intraocular pressure. And to differentiate it from cataract, the main problem rests on the crystalline lens that have turned opaque. In glaucoma, there's damage to the optic nerve, okay? And it's often due to increased intraocular pressure. Now, pay particular attention to the fact that glaucoma has a genetic basis. So, how would you know that a client could be having glaucoma? Well, the patient could initially complain about tunnel vision or gun barrel vision, or they would describe it as they feel as if their vision is closing in from both sides, and everything on the sides could be dark, and the central area could just be the ones where they get to see something. So this creates a tunnel effect when they try to see things. Now, other symptoms of glaucoma could include halos around lights, okay, dim vision, frequent changes in eyeglasses, just like a client with cataract, and of course, dim vision. And sometimes you could have blind spots. And of course, the characteristic or most outstanding sign that differentiates it from cataract is the loss of peripheral vision. That's what we're describing a while back, that it's being described by clients as gun barrel or tunnel-like vision. So if it's cataract, usually it's a central vision that becomes blurry. If it's glaucoma, it's the peripheral vision that could be affected. And of course, the patient could also have severe headache, eye pain, and vomiting. Okay, now let's compare again the treatment for a client with cataract and for a client with glaucoma. For a client with cataract, we prepare the client for surgery, and so therefore we give them mydriatics, drugs that dilates the pupils. For clients with glaucoma, we give the client medications that constricts the pupil, like pilocarpine, and that's your miotic. We also give clients with glaucoma beta blockers or carbonic anhydrase inhibitors. Example of beta blockers would be timolol, maleate. Example of carbonic anhydrase inhibitors would be acetazolamide. Now, our beta blockers and carbonic anhydrase inhibitors would help decrease the production of vacuous humor, thereby decreasing the intraocular pressure. Now, some other drugs that could be given to the clients could be your prostaglandin agonists like lantaprost, and this is given to increase the reabsorption of aqueous humor, further decreasing the intraocular pressure. Now, mydriatics should never be given to clients with glaucoma. Why? Because these drugs could potentially increase the intraocular pressure. Okay? And when glaucoma persists, eventually it could lead to blindness. So it's very important that regular eye checkup and a visit to the ophthalmologist. Remember, an ophthalmologist is a doctor of medicine who specializes in eye diseases, and they can perform surgery. We differentiate them from optometrists. Optometrists are doctors of optometry who are specialized in assessing the eyes and prescribing the lenses. They can also treat eye disorders, but they cannot perform eye surgery to the extent that your ophthalmologist can do it. So which simply means that if the patient would need a revision of the eyeglasses, then refer them to an optometrist. But if they need further assessment for the possibility of having glaucoma or other eye disorders that could be more serious and would need more intervention other than just wearing eyeglasses, then you need to refer the client to an ophthalmologist. So that's the difference between the ophthalmologist and the optometrist. Okay. Now, if you would note here in the picture that is being presented, the eye that has glaucoma is the one that is usually reddish. And if you would take a look at the central area, okay, the pupils would usually not react to light, especially if this is closed angle glaucoma, where the intraocular pressure is higher than in open angle or chronic glaucoma. Okay, now let me congratulate all those who pass under our system. We have hundreds of thousands of passers from all around the world who've been passing their next generation NCLEX through the Gapuz system. Now, the third concept that I'd like to highlight at this point would be the concepts related to retinal detachment. So when you hear a patient say, I'm having painless, blurry vision, and I think I've lost my central vision, then suspect cataract. But if the patient would say, I'm having tunnel-like or gun barrel vision, and the peripheral part of my visual field are all dark, then suspect glaucoma. But if a patient would tell you, I see floating spots in front of my eyes, I see veil-like structures in front of my eyes, I see web-like structures in front of my eyes, then you suspect retinal detachment, okay? Because floating spots in the visual field is characteristic of retinal detachment. Now, pay particular attention to the fact that the main problem in retinal detachment is the detachment of the pigmented retina from the sensory retina. So signs and symptoms could be the characteristic visual floaters, okay? Then loss of peripheral vision or the presence of a shadow-like or curtain-like thing on your visual field. Definitely, the intervention would involve several types of surgery like pneumatic retinopexy, in which the surgeon injects a bubble of air to push the area of the retina containing the hole against the wall of the eye, thereby preventing further detachment. Or they could do scleral buckling, in which the surgeon would actually sew a piece of silicone to the sclera to indent the eye and push it back into its normal position. Or they could remove the vitreous tumor through a surgical intervention known as vitrectomy, okay? And then they replace that with air or gas or silicone, which will eventually flatten the retina. So all of these surgical interventions are meant to prevent further detachment of the retina. Now, the most important thing that you have to remember for your test is the fact that if a client has retinal detachment, remember to always position the client on the affected side to prevent further detachment. And there are certain things that you need to modify at home when the client gets discharged. Like, for example, instruct them to avoid any activity that may increase intraocular pressure, like bending or reading or coughing or doing the Valsalva's maneuver. And definitely you will have to instruct them to modify their home lighting. So instead of bright lights, they should use warm lights, because there are studies actually that say that halogen or incandescent light could potentially harm the eyes if these are used for a prolonged period of time. So bulb that emits warm lights could be more preferred than those that emit very, very bright lights. So without further ado, here's our first set of pointers. Now, the first question that you have to ask yourself when you're preparing for the next generation NCLEX-RN is, where do I begin? What are the things that I need to master? What are the concepts that I need to focus on? And for you to be able to answer these questions, you need an expert opinion. And this is where our system would come in. Of course, we have experienced mentors. I, for one, have been monitoring the trends on the NCLEX since the 90s. So you talk about more than 3 decades of experience, and that's something that we at the Gapuz system consider as our main advantage. So the first concept that I'd like to highlight, especially for those who are taking the test anytime soon, would be scarlet fever. And take note, for scarlet fever, it is usually triggered by a strep throat or streptococcal sore throat. Now, the most outstanding manifestation of scarlet fever would be the presence of your sandpaper-like rashes, and medically, this is called pastelines, and this is described as the presence of hyperpigmentation on the skin. Now, the presence of a red strawberry tongue also signifies the presence of scarlet fever. Now, since this is an infectious condition, the treatment would usually involve antibiotics like your penicillin and erythromycin. So since these antibiotics could potentially trigger an allergic reaction, it's very important for the client to inform their healthcare providers if they have any allergies. And should there be any allergy, usually the healthcare provider would provide an alternative medication, and the alternative medications could be cephalosporins, azithromycin, or clarithromycin. Now, what is significant to note when your client has been diagnosed with scarlet fever is to pay particular attention to the potential development of complications. Now, the most common complication could be your rheumatic heart disease, okay? Now, how would you know that the patient could be developing rheumatic heart disease? Pay particular attention to the development of polyarthritis or painful tender joints, specifically in the lower extremities, specifically the knees, the ankles, and in the upper extremities, the elbows and the wrist. Now, there could also be uncontrollable movement, otherwise known as chorea, and of course, the presence of chest pains and palpitation. So, for the most important discharge instruction that you have to tell your patient, focus on compliance with the treatment, specifically with the antibiotics, And of course, we need to tell them to avoid getting themselves exposed in crowded areas. Okay? Now, the second, and this is an important topic that I'd like to highlight because more often than not, we know very, very few things about toxoplasmosis. So, this is a parasitic condition. It's actually caused by a protozoa known as Toxoplasmosis gondii that's transmitted either through cat litter or half-cooked meat. So, pregnant clients who usually develop the infection eventually develops complications specifically for the baby. So infection with toxoplasmosis could be fetotoxic. Therefore, always instruct the pregnant client not to do the discarding of the cat litter box. And of course, even cleaning it, they have to avoid it. And they have to use gloves while gardening. And the most important thing, before they eat meat, they have to make sure that it's properly cooked with the appropriate temperatures. Okay, now there are three body parts that are affected in toxoplasmosis. It affects the lymph nodes, the central nervous system, and of course, the muscles. So therefore, the main symptoms would be muscle aches, lymphadenopathy, and sore throat. Now, there are two specific drugs that you have to remember, and the drug of choice could be dependent on whether the client is pregnant or not. So if the client is pregnant, the drug of choice would be pyrimethamine. And if the client is non-pregnant, the drug of choice could be any of your sulfonamides. Example would be your sulfasalazine, okay? So these are anti-parasitic drugs. Now, what is the danger of toxoplasmosis? Since it affects the central nervous system, it could potentially cause seizures. So it's very important to inform or provide information to the client related to the impending signs of seizure. Like, for example, if the patient experiences headache or visual or auditory hallucinations or seeing flashes of light or hearing strange sounds, it's very, very likely that the parasite has infested the brain. So it's important that the client should be told that they need to report this to their healthcare provider. Okay? And of course, I'd like to congratulate all our passengers from all around the world, and we are having hundreds of thousands of them from more than 30 countries worldwide. Now, the third concept that I'd like to highlight would be mastitis. Now, you wouldn't believe it, but the most common source of the infectious agent that causes mastitis could be the baby's mouth. However, even if it could be related to the presence of microorganisms in the baby's mouth, you have to instruct the patient to still continue breastfeeding the child, even if they're having mastitis. So in mastitis, focus on the syndrome that defines it. You have fever, you have swelling, redness, and tenderness of the breast. Okay, so that's related to the presence of infection on the breast tissues. Now, in severe cases, the client could have nipple discharge and even swollen lymph nodes. What is important is the client is given the right combination of treatments like antipyretics, analgesics, and of course, antibiotics because you have an infection. And the priority for these clients would be maintaining adequate hydration, continuing breastfeeding the child, and of course, increasing caloric intake by 500 calories per day because you are breastfeeding the child. That's if you only have one baby. So 500 calories for each baby being breastfed. So if you have twin babies, then that goes up to 1,000 calories, okay? And then we instruct the client to wear snug-fitting bra and provide proper nursing care. Proper nursing care could mean you instruct the client to either have hot compress or warm bath to relieve the pain on the tender breast tissues. And of course, we also can alternately use cold compress to relieve pain and to suppress lactation. So once again, the baby must be fed, even in the presence of mastitis. So instruct the client to continue breastfeeding the baby. Now, the second issue for those who are preparing for the NGN is, how do you study? You have to learn how to study with technology. So there's one student whom I remember telling me, because I asked her, why didn't you get a perfect score in a test drill that we had? And her answer was, Sir Ray, in my mind, I know the right answer, but I cannot just seem to coordinate how I navigate the use of the mouse, such that when I press on it, it kind of slipped from the option that I'm supposed to click to the next one. And so she wasn't able to navigate the technology properly, so she's getting incorrect answers. So it doesn't necessarily mean that if you're getting low scores that you don't know your concepts. It could simply mean that you're not yet adept with the technology required to pass NGN. And with the Gapuz system, we have our own technology. So let's begin. Without further ado, let's start with the first question. Of course, the first question that we need to ask ourselves when we're preparing for the next generation NCLEX-RN is, what are the things that we need to study? And we can't do that decision on our own. We have to ask and obtain an expert opinion. When I say expert opinion, it has to be from someone who has seen it all. It means a mentor who could actually give you an overview of a concept that was based on the history of how these concepts are being asked in the actual test. And at the Gapuz system, you are sure, me being, I think, the only nurse in the world who has monitored NCLEX since the 90s. So I've been there, I've done that, and have taken the exam almost every time that they offer new sets of innovative items. Okay, so let's begin. And the first concept that we'll cover will be about adenovirus. Now, if you think about adenovirus, think about a range of illnesses such as the common cold, sore throat, conjunctivitis, acute bronchitis, pneumonia, gastrointestinal upsets or distress, and you need to focus on the type of isolation precautions that you need to implement. Now, for example, if I'm going to give you a key point related to adenovirus, the first thing that I'd like to highlight would be what type of isolation precautions would be appropriate if your client is exhibiting adenovirus conjunctivitis signs and symptoms. Like, for example, if the patient is having pink eye or reddish eye and inflammation, okay? So think about adenovirus conjunctivitis. In that case, think about two important things. You will need to implement contact isolation precautions and standard precautions. But what about if the patient is having adenovirus pneumonia, in which case you will need to implement standard precautions. Now, remember, the most significant and the most important thing, or the most important thing that you have to remember related to adenovirus would be the isolation precautions that you will need to implement, okay? Now, the next concept that I'd like to highlight would be cataracts. Now, remember, cataracts would be described as the opacity of the crystalline lens, and it could be due to accumulation of abnormal proteins in the lens. Now, how would you know that a client has cataract? Well, first, they will be complaining of blurred vision, and then the lens that are usually clear would appear milky or cloudy. But take note, the blurring of vision is usually painless. Sometimes they also complain of double vision or gradual loss of central vision, and including frequent changing of eyeglasses, as well as shifting or change in color perception and sensitivity to glare. Now take note, if cataract is not properly managed, blindness can occur. But remember, the only treatment for cataract is surgery. and that would involve the extraction of the cataract. So preoperatively, the patient will be given pupillary dilators or your mydriatics, such as phenylephrine or atropine sulfate. And take note, what is important for you to note, if I'm going to give you an advice, would be the interventions that you need to remember after cataract extraction. And that begins with the independent nursing intervention of positioning the client. Now, always remember to position the client on the unaffected side, or you need to put the patient on a semi-Fowler position. Now, if after surgery, the client complains of flickering lights post-operatively, we assure the client that this is usually a normal or expected part of the healing process. Now, upon discharge of a client post-cataract extraction, what are the things that we need to instruct the client to be familiar with? First and foremost, we need to instruct the client that they have to wear the eye shield as directed. And it's also very important that they wear sunglasses when they're outdoors, and they need to avoid any activity that may potentially increase intraocular pressure, like bending, coughing, okay, straining during defecation, especially if they are constipated, heavy lifting, that's usually more than 15 pounds, and performing the Valsalves maneuver. We also need to tell them to not to scratch the surgical site. Now, one of the most important instructions that we have to tell the client post-cataract extraction is they have to be oriented as to the common manifestations that indicate a potential development of a complication. Like, for example, if the patient complains of sudden severe eye pain, that indicates hemorrhage. If the client complains of visual floaters, then that indicates retinal detachment, which could be a complication. And then when the client complains of pain that comes with nausea and vomiting, that could be indicative of increased intraocular pressure. And then if discharges, either greenish or yellowish, are noted, that could mean there is an infection. Now, what specific modifications in terms of the client's environment need to be addressed? First and foremost, after cataract extraction, the patient becomes sensitive to glare. So instruct them to avoid bright lights, and they could initially, use the indirect types of lights in the room. And of course, we also need to tell them to use artificial tears like Systane, that's Systane, and use it 3 times a day or as directed by the ophthalmologist. Okay, next, let's move on and let's talk about your gestational trophoblastic neoplasm. Now, in gestational trophoblastic neoplasms, usually there's an abnormal trophoblastic cells that grow after a molar pregnancy. Now, how would we know that the patient is having gestational trophoblastic neoplasm? First and foremost, pay particular attention to the group of signs and symptoms like the presence of bright red vaginal discharge, an enlarging uterus, severe nausea and vomiting due to an elevated human chorionic gonadotropin. And then pay particular attention to the fact that there's usually a passage of grape-like cyst from the vagina, and signs and symptoms of hyperthyroidism can occur because of elevated human chorionic gonadotropin. So once again, focus on those signs and symptoms. Now, what are the things that we need to anticipate as a form of treatment for clients with gestational trophoblastic neoplasm? Of course, we need to prepare the patient for surgery, dilatation and curettage, and then chemotherapy or a possible hysterectomy. And focus also on identifying manifestations of complications related to surgery. For example, there could be infection. So note for the presence of fever and greenish or yellowish vaginal discharge. Note also for the potential of bleeding to occur after surgery. And of course, potential for uterine perforation. Now, the most important discharge instruction that you have to provide the client with gestational trophoblastic disease in order to prevent gestational trophoblastic neoplasm would be to avoid pregnancy for 6 to 12 months after the evacuation of your gestational trophoblastic growths. And so this would require the client to use contraceptives. So there should be strict follow-up as well as monitoring of the client's human chorionic gonadotropin levels. Okay, so the next question that we need to ask ourselves is, can we navigate through the NGN by just studying concepts? The big answer is a big no. Okay, so you have to learn how to navigate and answer questions using technology. Here at the Gapuz system, we have our own technology-enhanced learning tools. So let's begin our pointer set number 39 with the question, what do we need to study? So on my list for this set, first is alcoholism. Now, let's remember the definition of the World Health Organization. So according to the World Health Organization, alcoholism is not directly associated with how much the patient drinks, but it is best judged on the effect of alcohol drinking on the individual's health, economic functioning, and interpersonal relationships. So if we're going to differentiate excessive alcohol drinking from alcoholism, there's a very thin line. However, if the patient, for example, a male, have 5 or more drinks within 2 hours, that is considered unhealthy alcohol use. And for females, if they've had 4 or more drinks within 2 hours, that's also considered unhealthy use of alcohol. So when are they considered alcoholic? When they can no longer perform their function if they are not drunk, which simply means they are driving while drunk, they are swimming while drunk. So in essence, they cannot go on with some activities without feeling the need to drink. So an alcoholic patient, therefore, will have numerous attempts in their alcohol history that would tell us they tried to stop taking alcohol, but they just can't. That's the first step in the rehabilitation of the alcoholic client. They have to acknowledge that there is a problem. And that's what we call in mental health and psychiatric nursing as the development of insight. Okay? So if the alcoholic patient is denying that there's something wrong with them, it's difficult to rehabilitate that client. Okay, so the next topic or concept on my list is actually your cretinism. Well, cretinism is congenital hypothyroidism. Primarily, this is due to deficiency of thyroid hormone, and this could be related to the lack of iodine in the mother's body during pregnancy. So how would we know that the baby has cretinism? Well, a general characteristic would be that the baby will be described as a well-behaved baby, the baby who seldom cries, the baby who always sleeps, the baby who will not exert effort to suck and feed from the mom, okay? They cry very little or very seldom, and usually they could either have pale skin or jaundice. Now, is this condition preventable? Well, the use of iodized salt can help. However, it is best if pregnant adults would increase iodine approximately 220 micrograms per day in their diet, okay? And for non-pregnant adults, 150 micrograms per day would help prevent cretinism. So once again, a complication of cretinism is mental retardation. And remember, the child with cretinism looks well behaved. Remember,
So if you have a well-behaved baby, that is a red flag that should alarm healthcare providers. Okay, and of course, last on my list for this set would be hyponatremia. Now, just like in a previous video where I shared concepts related to hypokalemia, hyponatremia may not necessarily be presented as an isolated condition. It could be presented in relation to SIADH, or your syndrome of inappropriate antidiuretic hormone secretion, in which, due to fluid retention, dilutional hyponatremia occurs. So whenever the sodium level falls below 135 milliequivalent per liter, then we suspect hyponatremia. And when we think of hyponatremia, there are two main systems involved that would be reflective of the signs and symptoms that the patient would manifest. Remember, chin, so the patient will have confusion, headache, irritability, nausea and vomiting, and when the sodium goes lower than 120 milliequivalent per liter, the client would go into seizures. So if a patient is having hyponatremia, you may want to think about implementing or anticipating the implementation of seizures precautions. So the priority intervention for a client with hyponatremia is to administer IV sodium solution. Okay, so how do you study for NGN? There's only one advice I can give. Study with the right tools and the right technology.